Assalamu alaikum. Thank you for inviting me to this meeting. Today I will speak about myeloablative haploidentical donor hematopoietic transplantation using BTCY and ATG. This is to summarize our experience in King Faisal Specialist Hospital. So as a background, haploidentical stem cell transplantation using T-cell replete HLA haploidentical first degree related donor from sibling and parents with post-transplant cyclophosphamide to control alloreactivity is a standard option in the absence of matched donor. Different protocol or transplant platforms using different graft sources and conditioning depending on the underlying disease have been published. The standard haplo transplant platform for malignant hematological diseases at King Faisal Specialist Hospital and Research Center using a myeloablative conditioning regimen and BTCY followed by MMF for 1 month and calcineurin inhibitor for 6 months for graft versus host disease prophylaxis. The graft source is unmanipulated primed bone marrow. However, during COVID-19 outbreak, peripheral blood stem cell source was used in a number of patients. After using this protocol on the first 10 cases, high-grade acute GVHD was noted, and as a result, antithymoglobulin was added. We herein report 60 malignant hematologic cases transplanted on this modified protocol. So 60 consecutive leukemia and MDS patients received myeloablative haplotransplant at King Faisal Hospital between June 2016 and September 2022. Subjects received a graft from a family member sharing one HLA haplotype with the recipient, but differed to a variable degree from HLA A, B, and DR antigen of this unshared HLA haplotype. Patient characteristics were summarized using frequencies for variables and medians with range for continuous variables. The primary endpoints were the 5-year overall survival and relapse-free survival. Secondary endpoints included engraftment, graft failure, GVHD, and CMV reactivation, non-relapse mortality, and toxicity. So these are the characteristics of the patients. Male to female, 53% to 46%. And this is the recipient. And the donor, male to female, 56, 43. Recipient median age. So as we see, most of them are less than 50 years old, like 53%. Donor median age is 31 years old. And this is the donor-recipient gender mismatch, male to female, 20%, female to male, 23%, male to male, 33%, and female to female, 23%. Donor relationship, parents, 13%, sibling, 60%, offspring, 26.7%. Recipient donor level of HLA match. So if it's 50%, it's 41.7%, but others that more than 50% match, like 58.3%. The ABO mismatch, major mismatch 21%, minor 80.3%, no mismatch 70%. These are the diagnoses: AML, ALL, APL, MDS. As we see, most of them are in the acute leukemia group. The DRI, which is the disease risk index, most of the patients are the intermediate to high risk. Conditioning, TBI is 31%, and TBI mainly used for ALL group. Non-TBI, mainly for the AML group, 68%. The graft source, as we said, most of them are bone marrow, 73%, but during COVID outbreak, we used the peripheral blood, 26%. The infused cell dose, the median is 3.7 million CD34. These are the results: 5-year overall survival, 59.2%, and 5-year relapse-free survival is 48.6%. The chronic GVHD relapse-free survival, CRFS, is 40%, non-relapse mortality 21.6%, transplant-related mortality is 11%, the engraftment in neutrophils is 16 days, the median time until engraftment, 16 days, and the median time for engraftment of platelets, 28.5 days. The acute GVHD is 51.7% of the patient have acute GVHD, 46.7% are grade 2 to grade 4. The chronic GVHD is 36.6%, and these are the distribution among limited and extensive disease. The CMV reactivation, more than 20, the PCR is 88.3%. The SOS, sinusoidal obstructive disease, percentage is 3.3%. Hemorrhagic cystitis percentage is 28.3%. ICU admission 28%. The primary graft failure, we have 0 graft failure among these patients. And for secondary graft failure, we have only 1 patient, 1.7%. So as a conclusion, the use of PTCY may not yield the same result in different populations. So because some centers, they don't use the ATG, but in our center, we found that the addition of ATG might help to reduce the GVHD. Adding ATG to PTCY decreased GVHD in our patient, but may have increased relapse and infections. Dose and timing need to be addressed in larger trials. The use of ablative regimens in older patients was associated with unacceptable high non-relapse mortality. Higher disease risk index and 50% HLA match were associated with lower relapse-free survival. On the other hand, female-to-male donation and older donor age were associated with higher risk for chronic GVHD and the use of peripheral blood, and did not seem to increase the GVHD. Thank you.
Thanks, Moamen.